We're going to get started in just a second here. We'll give people a chance to get assembled. Let's see who's here. Who's already here. I wound up in our dog room today. It was the only quiet place in the house to do this. I hope you'll forgive me. We run this medium-sized dog psychiatric hospital. We have 4 Chihuahuas, and each one of them is more crazy than the other. But we love them. They're great. I never thought I'd be a Chihuahua person. I never did. But once you get a Chihuahua, well, that was it for us. We just love this breed, and we rescue them all the time, and nothing but chaos, right? Every one of them is such a unique personality and delightful. You can see that's Fatty over there. Fine specimen of an animal. Who's this? Oh, yeah, that's this one, Maxie, we inherited from a humane society. Believe it or not, there's a couple more in here. But anyway, they won't bother us, so you don't have to worry about that. You don't have to worry. Let's see. I'm trying to get a list of our participants, our early birds that are here. Hopefully you can hear me. If you can, put a message in the comments just as we get set up. Oh no. As we get set up, we'll be able to make sure everybody is able to hear. Heather, you'll be glad to know, will be joining us. She'll be on the chat side, though, and so she'll be moderating questions. Any questions you might have that pop up, she'll answer. And if she needs me to put my 2 cents in, then that question will get directed towards me, and I will do my best to answer it as well. Heather, if you're here, I'm not sure if you're on yet, but send me a message or put it in the chat or something, so I know that you are ready, because we're getting close. Just a couple more minutes. Heather says she's on. Oh, there she is. Pelvic floor solution. Very good. You guys, if you don't know how to leave a message in the chat, probably you have a little window down in the lower right portion of your screen that you can use to get engaged in this conversation. And if you have questions about anything, then don't be shy. Ask them. And Heather, as I said, will moderate those questions. I think we're going to get started in just a second. Let's do a couple of housekeeping things. Number one, I've received clear instructions that I should mention our Prolapse coaching course that is available at Phylates.com. How do you spell Phylates, you ask? P-F-I-L-A-T-E-S. So it's like pelvic floor Pilates. We just stuck an F in Pilates. And if you go to our website and navigate to the Prolapse coaching course, this is an awesome experience for anyone that is starting the journey of dealing with pelvic organ prolapse, giving you what you need to employ a conservative non-surgical solution, but also helping you if and when you need to pursue a surgical option. we can walk through that with you. So it's a multi-week live experience. You'll get a lot of personalized attention. And right now, when you go to sign up, it'll show that there's a waiting list, which we just put up. And as we collect participants, then we will get the final course dates for you. And of course, you'll have access to the content, even if you're not on the live portions of the program, you'll still have access to it. There's all kinds of educational materials, downloads, and it is a plethora of information, because you know what? This process really matters. If you're considering having an operation for pelvic organ prolapse, you need to make some decisions correctly, right? Some decisions, it doesn't matter so much if they're correct or not. This is not one of those situations. You got to make the right choices and have the right information. That gives you power, right? That is empowering. And so why wouldn't you do that as you consider going to sleep in an operating room, for instance? Or if you very much want to avoid that, we can make sure you're moving in the right direction. I think you'll be really happy with it. In addition to that, some people want to just stick their toe in the water. And for that, we have a free service that you can check out, learn one of the Pilates movements directly from Heather via video feed that's accessible. And the link to that experience and the link to the Prolapse course are both going to be in the description section right down below. So this is so simple. All you have to do is click on the link. It'll take you right to the page you need to be at, and you can get signed up. Couldn't be easier. Couldn't be easier. And so Heather's given me feedback, and I anticipated her feedback and told you that the links are in the description, but she informs me now they're also in the chat. So check out the chat. Both links are there, and you should avail yourself to them. 501, well, it's 401 here. Let's get started. It's 701 where you are. So good for you after a long day, getting more education, doing more. That's terrific. That speaks to a proactive personality that wants to empower themselves. And that's exactly what's going to happen today as we talk about the realities of surgery for pelvic organ prolapse. Most of you know I'm Dr. Bruce Crawford. I'm a board-certified urogynecologist, a reconstructive pelvic surgeon. I have done many thousands of reconstructive pelvic surgeries, and I am well equipped to share with you the realities, and we can do it in a way where you're not feeling time pressured the way sometimes you feel when you're in a doctor's office, right? If they're asking if you have any questions with one hand on the doorknob, right, it doesn't really make you feel like they want you to have questions, and they probably don't. And yet we spend a lot of time talking about things like informed consent. And it's kind of an impossibility, frankly, to give a patient enough information that they really understand the risks, benefits, and alternatives in a detailed, meaningful way. I've spent a lot of time doing volunteer work, surgical work in West Africa. And, informed consent there is a pipe dream at best, right? But even if, there isn't a ridiculous language barrier and, background education necessary to understand surgical realities, even in this country, informed consent for most people is fanciful, right? Like we think we obtained informed consent, but did we? Right? If you asked the patient to write down what are the indications for this surgery, the risks, benefits, and alternatives, and you read it, I think doctors would be discouraged with their ability to obtain a legitimate informed consent. It's a difficult process that takes time. It takes time. And there's different types of patients. There's the type of patient that says, I don't want to know anything, just do what you need to do, right? The just fix it patient. And then there are patients that come in with a lot of printouts from Google searches and articles, and they are more detail oriented, and they have more specific questions. But a lot of times the questions and concerns they have aren't the things that are going to happen or could most likely happen, right? And that's what we're going to talk about today. And so if you are at a point where you've considered conservative options, pelvic floor rehabilitation via the Pilates method, for instance, or a pessary device, or just living with it, if you've considered all these things and you're at a point where you say, that's not what I want to do, I think surgery is the best option for me, well, then you're in the right place. That's what you're here for today. Now, choosing your physician, let's talk about that for a second. This should not be a passive process. It shouldn't be the only one that could get you in. It shouldn't be the only one that's in the area. It shouldn't be, well, my friend said this was a good doctor. That's probably not the best way to choose, right? When you're choosing a surgeon, what matters is their experience, and within every medical field, as it develops, it becomes more and more specialized, right? There used to just be gynecologic surgery, right? Now, reconstructive pelvic surgery has become a specialty unto itself that requires a great deal of effort and practice and additional training and ongoing continuing education. And so, it doesn't mean there aren't great gyne surgeons that don't list themselves as urogynecologists. There certainly are. But, a doc, fresh out of fellowship or fresh out of training might need a few years to mature into the specialty. Might, if you're going to start screening doctors, that might not be your first choice, but rather, someone in their mid 40s, 50s are probably kind of peaking at their skill level and their intellectual capacity, and that might not be a bad age range to choose from. And then, I think a lot of patients are afraid to ask physicians questions that they're afraid would make the doctor uncomfortable. You should not be afraid of that, right? How long have you been doing this? How many of this type of procedure have you done? What's your success rate? And if they hem and haw about answering a question like, how successful is this procedure for you? That probably means they don't know, because they've never actually collected their own data and analyzed it. That's not a good sign, right? If you really are passionate and care about the 10 or 12 operations that a urogynecologist does, then you should keep track of how your patients are doing, at least, immediately after surgery. But, for another 6 months to a year. Now, sometimes patients go away after the 6-week post-op check and you never hear from them again. And so, it's hard to say, what your success rate is when your patients disappear after 6 weeks and you don't hear from them. Maybe they got treated again by a different doctor and you never knew about it. Maybe they had a late complication and you never heard about it. And so even if a physician says, well, I have very low complication rate and very high success rate, and it's like, well, yeah, but do you really know that? And so really, I think you're in a much better position to assess the near-term kinds of problems that you can have in the operating room or in the first few days after surgery. Bleeding and infection basically is what we're talking about. If we're using materials in the operating room like synthetic grafts, those can create a unique category of complications, specifically pain problems, erosion problems, specific type of infections that can occur when permanent synthetic mesh is used. But you need to ask your doctor about that and then kind of sit back and see how they answer. If they have the data and are very forthcoming with it, that's what you want, right? Every surgeon has complications, right? Every surgeon does procedures that fail. And so if you were ever to hear, well, I've never had a complication or all my patients are successful, then you need to go to a different doctor, because that is not true. And it's not reassuring that this physician has the integrity of a good physician, right? They need to not be intimidated by these questions. They need to display that level of maturity. And so, searching out a board certified urogynecologist might be a good thing. It doesn't guarantee that they're great, but it's a way to start narrowing the field as you make a choice. Well, what if I have to leave town and go to a different town, a bigger city, to get a better choice? Well, this is a pretty important decision. Maybe you need to do that. Maybe this is a time when convenience isn't the most important thing. Maybe results are the most important thing. And then you can look at, physician reviews, people's testimonials online. There's various different kinds of websites that try and curate what people have to say about physicians. It's not clear that those can't be altered to remove or make less visible the negative responses. So take it with a grain of salt. And a lot of those reviews will be positive, but you look at the positive reviews. If the positive reviews are of the sort that says, she's so nice, or he's really compassionate, or, who cares? This is a surgeon, right? You're not hiring your best friend. Everyone wants a doctor that's nice and compassionate and warm and fuzzy. You really want? You want a doctor that can make good decisions in the operating room under pressure, that is confident in what they do. And that's the kind of thing that you might want to look for if you're evaluating reviews and testimonials. Again, not the easiest thing in the world, but when you meet with someone, you can kind of get a sense of their personality, right? Again, you're not hiring a best friend. You're hiring someone with a technical skill that you need. And then after 6 weeks, there's a chance you won't see him again, or not very often, So try and not get too hung up on how nice or they are or anything like that. It's their professional reputation, and to the extent they'll share their own data with you, to the extent they have data, which they should, you can maybe make a better decision. Now, they should have communication skills that allow you to express yourself, that allow you to ask questions without being intimidated or feeling rushed. If you don't want to, the other side of that coin is you don't want to hire a jerk either that isn't going to, get back to you post-op if you have a concern about how things are going, right? And a lot of times, that has more to do with the office staff than the doctor anyway. But, the doctor is responsible for the office staff and how they handle their patients. The doctor's not answering the phone. And so how your calls get processed is another thing to consider, right? Because that needs to happen in a way that's expeditious post-op, because, complications can and do happen. And when that's the case, time is of the essence. You got to deal with it, and not tomorrow or the day after tomorrow, right? And so that's another thing that maybe you can assess during your visit. Find out who this doc's medical assistant is, or who's running the phones for this doc, and make sure you take note of their first name, and maybe make sure you introduce them and have a little extra conversation. Right, bring them a latte if you have to, right? and so that if and when you need them to be there and be responsive to your needs, then hopefully they'll be responsive to your needs. What else? Let's see if Heather is good. We're doing good. And so that once you've chosen a physician, Then, preparing for surgery. And you can expect at least one visit that is designated the pre-op visit. And it's at this visit when the process of informed consent is attempted. And you'll be given a bunch of forms to sign that say you understand the risks, the benefits, and the alternatives of this procedure. Lab tests generally be ordered, and it's not the same for everyone. Most everyone will have some blood work done, usually hemoglobin, hematocrit, white blood cell count, platelet count. And then depending on medical problems you may have or age, other lab tests, chemistries might be done. And a chest x-ray and EKG might be needed preoperatively. And so that is all pretty routine. And hopefully you have access to your results through an app or some such thing to, so you can see results that are out of range. And as your doctor no doubt will as well, anesthesia always takes a look at that too before they come to talk to you in the preoperative holding area. Usually you don't have a choice about who your anesthesiologist is, but this is something that people don't know. Like if there's one or two or more groups of anesthesiologists servicing the same facility where you're going to be having your surgery, and you know of a doctor that does anesthesia that you like, you can call that group. They have a number where they do all their administration. Someone's going to answer the phone, and you can request a specific anesthesiologist for a specific procedure on a specific day, and they will probably do it. I know that was always true where all the hospitals I've worked in. The anesthesiologist, if they get a private request, first of all, they like that, right? Because it's sort of validation, it makes them feel good. And they kind of some of them even get points within their group that kind of help them out. I don't know how that works exactly, but I know they appreciate it when someone calls and makes a private request. So you can choose your anesthesia, but no one thinks to do it, right? There's like whoever shows up, like a soap opera doctor, is going to be good. Probably they are. And usually with these kinds of surgeries these are elective surgeries. It doesn't mean they're not necessary. They're necessary, but they're elective, meaning you're not going to die tomorrow if you don't have this surgery. With these surgeries, anesthesia is usually not complicated. It's usually pretty straightforward. It's very low risk. And so that's all great news. But again, if you want to participate in the choice of your anesthesiologist and you know of one you like, then you can probably request that a doctor. What else? Medications before surgery, your doctor will be very specific about what they want you to take. A lot of times they will want you to take your blood pressure medication, or if you're taking a water pill, a diuretic, they might want you to take that the day of surgery with a small sip of water. But make sure you ask, because there's other medications they for sure you will not want you to be taking. For instance, they'll tell you to stop taking drugs like ibuprofen or aspirin, 10 days, 14 days before surgery. If for some reason you're taking aspirin, probably at least 14 days before surgery. And that's because it can interfere with the way the platelets work, and platelets are necessary just for bleeding to stop. When you do surgery, the surgeon has techniques to control bleeding, but also relies on the body's physiology and the tendency for blood to clot. And when it won't clot, it is an enormous problem in the operating room. And so obviously, if you're taking drugs like Coumadin or warfarin, blood thinners, heparin for any reason, those would also probably be stopped well before surgery. And your doctor will be very specific about that, but you can also ask about that. Usually 8 hours of fasting is sufficient. Most pelvic reconstructive surgery does not require a bowel prep. Anyone that's had a colonoscopy knows what a bowel prep is. It's like everyone says, it's the worst part of the colonoscopy, and I agree. and so, but usually that's not necessary with pelvic reconstructive surgery, unless there's a risk of having to perform bowel surgery at the same time, unless the surgeon anticipates a greater risk of bowel injury because of known adhesions within the pelvis or abdominal cavity that could be involving the bowel. If they anticipate a more complex dissection at the beginning of the procedure, then I was always pretty liberal with bowel preps, and I think that was more generational than anything else. I think the more recently trained physicians use them less, and there's probably good reason for that. Frankly, usually you don't need it until you do, and then it's a bad spot to be in when you wish you had done a bowel prep and you didn't. And so you can ask your physician specifically, do I need to have any kind of bowel prep, right? They're not all that giant go lightly bowel prep for a colonoscopy. Sometimes a doc will use an over-the-counter product called magnesium citrate that does a pretty good job deflating the colon. Not as complete as a full go lightly bowel prep, but still pretty good. The recovery process is another thing that you should anticipate. After surgery, you're going to wake up in the recovery room, and there probably will be some discomfort. But the good news is that pain should be quite manageable, and you'll already have pain medicine in your system from the anesthesiologist. They almost certainly will have given you some form of an opiate during the surgery, so you're not waking up completely unmedicated and then have to catch up. The trick with post-operative pain is to keep up with the pain, not get behind on it. And so it's not a sign of weakness to take pain medication. I don't know where that idea comes from. I didn't need anything. Like, who cares, right? The thing is, it's dangerous to not control your pain. What do I mean by that? I mean, if you're not controlling your pain, you're less likely to get out of bed and move around. More likely to get a blood clot in your leg that could break off, go to your lungs, and kill you. That's called a pulmonary embolism. If you're in uncontrolled pain, you're less likely to take a deep breath, more likely to get a pneumonia, which could become very serious. And so if you're having surgery, control your pain. And part of that is communicating with your providers. Maybe you're home already and you have a prescription for a few days of pain medication, but it's not doing the job. Pick up the phone and call. These people work for you, and let them know, my pain's about a 6 out of 10. I'd like it to be under 4. Can we make some adjustment? And they might say, well, keep taking the narcotic we prescribe, but maybe add a little ibuprofen. They might say something like that. That isn't really too much of a change, but little things that can make a big difference. And so that's something that you want to be able to communicate, pretty directly with your provider about. What I always would tell patients is you should get better every day. Every day should be an improvement. You don't want to be getting better. Now I'm worse than I was the day before. Now I'm worse than that, right? That's always a telltale sign that there's something brewing that you may have missed. And so you want to let your physician know if you're making progress and then all of a sudden you're backsliding. A lot of times with bigger surgeries, I'd find like patients would look better on, the first day after surgery than they would the second day after surgery, because their cortisol levels are so high, like right after, like surgery is controlled trauma, right? And so you do this operation and their cortisol levels are really high. And that makes everybody feel good until your cortisol levels go down, which they do, usually, by the second day they're lower. And so people get a little more punky the second day. And it's, hit or miss. People are so different how they respond physiologically to a stress like this, but it is a physiologic stress. And, someone asks in the chat, what about for women that are 65 and older? And it's funny, we use that number 65 to somehow demarcate when someone's old. You know, there's 65 and 65, right? That by itself means nothing, right? If you're a healthy 65-year-old, you're going to probably do just great. You know, if you are a 65-year-old with diabetes and obesity and hypertension that's out of control, you know, or other medical problems, yeah, you're at greater risk for having a serious complication. That's not a newsflash to anyone, right? Your baseline health going into this grants you the risk you are going to be accepting, right? And so if you're in a situation like thinking, God, I'm dealing with this prolapse and it's really becoming more than I want to deal with, yeah, I haven't been doing the best about being compliant or seeing my doctor or taking my meds or managing my medical issues, maybe say, okay, here's the plan. 6 months, I'm going to give it. During that 6 months, I'm going to do something conservative, like take the Pilates online course. It's only $149. And then really try and mitigate these symptoms without surgery. I'm going to do that. And at the same time, I'm taking this 6 months and I'm not going to smoke and I'm not going to drink too much alcohol, right? Not more than, 1 or 2 drinks a week probably is how you should limit it. 0 would be best. And I'm going to really try the conservative options for 6 months. And then if that doesn't work, hopefully I'll have my blood pressure and blood sugar and other medical issues under control. Operating, this is another thing that people don't realize, and it's not a judgment, but I'm telling you as a surgeon, operating on an obese patient is just more difficult. It makes everything harder. And so to the extent one might be able to lose weight if they are, if the BMI is over 35 or something like that, it will make your doctor's job easier, which is good for you. You don't want your doctor to have a hard time. But even with vaginal surgery, excess weight can make it more challenging. And if it's not an emergency to get an operation, it does give you the opportunity to address that. In 6 months, I don't know. I mean, the way people are using the GLP-1 agonists now, Ozempic and the lot, for just like seemingly any indication, right? Like it seems like everybody's on one of these drugs. Like this is a kind of a legit indication. If I can lower my surgical risk and make my surgeon's job easier, that seems legit to me. Doesn't mean you're going to take it forever necessarily, but if you got a sizable operation coming up, that seems kind of legit to me in terms of mitigating modifiable surgical risk, right? So that's something also to talk to your doctor about. And it would give you time if you took this strategy to try and not have surgery at all, right? And Pilates actually does work. For women that have mild to moderate prolapse, and moderate prolapse or stage 2 means that the leading edge of the prolapse isn't more than a centimeter, about that much, about a centimeter beyond the vaginal opening, like 1/3 of an inch, right, beyond the vaginal opening. And those people do respond to fitness solutions like Pilates and don't have to go to sleep in an operating room. And that is preferable. It is. It doesn't mean surgery doesn't work. Doesn't mean surgery isn't safe. It is, but it's better to not have it. I think you can all agree. So having said that, and if there aren't any questions about the pre-op stuff and the post-op stuff, then I'm going to go ahead and move on to talking about some of the most common procedures that are performed and kind of how they're performed and what are the materials used, how well do they work, what are the kind of complications that can occur, in a way that probably is in greater depth than what you'll get even if you're talking to your surgeon, right? So that's why we're doing this, because I have the time to do this now. And you can come back to this video and watch it as many times as you want. And you can ask questions like what could be better, right? And so the first thing we're going to talk about is cystocele repair. Now, if you don't know what a cystocele is, good. It means you probably don't have one. But cystocele just means bladder prolapse, right? Or it's really talking about the top wall of the vagina upon which the bladder rests. It's talking about that dropping towards the vaginal opening, and ultimately it can drop beyond the vaginal opening, creating an uncomfortable bulge, and make it hard to empty your bladder completely. And it can be very distressing when you first discover it. Women seem to find these prolapses in the shower more often than anywhere else, and it causes a great deal of fear the first time it's discovered. A cystocele is not a dangerous problem. You can live with it, and you can live with it for years in most cases. So there really isn't this time urgency aside from the psychological impact of realizing you have a cystocele. It's not a dangerous problem. And the most common repair historically has been done through the vagina, so no abdominal incision, and is called an anterior, which means top, or referring to the top wall of the vagina, the anterior vaginal wall. It's called an anterior colporrhaphy. Anterior colporrhaphy is the most common way. It's really an operation lacking finesse, unfortunately, whereby an incision is made in the vaginal skin, and that skin is elevated off of the bladder, which lies right underneath it, and then using connective tissue that exists underneath the vaginal skin to create a colporrhaphy, or to sew together in the middle to create a shelf of support under the bladder, and then closing the bladder skin up, or closing the vaginal skin up over that repair. That's kind of the short version of how you do an anterior colporrhaphy. Now, back in the late 1990s, permanent synthetic mesh began to be used in vaginal reconstructive surgery, and is still used today by some docs. When that mesh is implanted through a vaginal incision, it's more likely to erode or cause a problem than when it's used abdominally in a procedure called sacral colpopexy, and we'll talk about that in just a minute. But the vaginal introduction of mesh seems to be more likely to cause erosion problems, maybe even in the 10% range in some series. And if it erodes, then sometimes that can be trimmed in the office without causing the patient too much distress. And then with estrogen cream in the vagina, the vaginal skin will kind of heal over that area of erosion. That can work. Sometimes that doesn't work, and you have to go back to the operating room to trim a more extensive area of that mesh, which can compromise the repair itself. It's not ideal. Usually that doesn't happen. Now, all of the meshes that exist today, when the healing process is finished, really won't and don't behave like biological tissue. They don't have the same softness, suppleness of normal biological tissue. They get a little bit and a little bit rigid. So it wouldn't be exactly the same after mesh implantation as before. And sometimes that can cause discomfort. Sometimes it can cause discomfort with intercourse. Anytime you have any kind of vaginal surgery, it's possible that as a consequence of that, intercourse will become uncomfortable. And there's a few different reasons why that can be. Mesh problems are just one subcategory of postoperative sexual pain, what your doctor would call dyspareunia. And that's a risk of all of these procedures. It can happen. And that's something that you're going to want to talk to your doctor about. Now, you probably don't want to get into too much of a conversation with your surgeon about how they approach an operation. Trust me, they approach it the way they're most comfortable with. And if they're going to do your surgery, that's what you want. However, if they're most comfortable doing sacral colpopexy through a big abdominal incision, but another doctor can do it robotically, and they've done lots and lots and lots of them and have a good reputation, your recovery is going to probably be quicker with the robotic surgery than with the traditional open approach to that procedure. So, that's something to consider. With that aside, your doc has done hundreds, if not thousands, of these operations, hopefully, and has settled into a routine that they are very comfortable with. And not only that, but their OR staff knows how they do a particular procedure and there's a rhythm to a surgery that involves your scrub nurse and your circulating nurse and your assistant. And it's not exactly the same every time, but there are steps, and your whole team learns the dance. And so you don't want to make your doctor do a different dance than they would normally do, right? So you don't want to micromanage that kind of aspect of the surgical plan, right? Like I said, like a urogynecologist does 10 or 12 operations. That's it. And they do them over and over and over again. And they get good at it. They get efficient at it. And that's why I feel like, private practice docs, and not academic docs, but docs that are out in the field in private practice, that, they don't have the same, they're not training residents, and they're not getting often, at least in the old days, aren't getting paid a fixed salary, no matter how productive they are. Like docs that are still in private practice get paid based on how much surgery they do and how busy, how productive they are. It seems weird to use that word productive in this context, but it's true. And honestly, they can't survive if they're having a lot of complications. They get weeded out of a competitive, non-academic private practice if they don't have the ability to operate with a low complication rate, because complications take a lot of time for the doc. And so, I think a busy private practice doc is going to do as good a job, if not better, than anyone, right? So you don't necessarily want the person that wrote the textbook, right? You want the person that changes tires all day, every day. That sounds a little bit crude, but what I'm saying is someone that is efficient and very, very practiced in a certain procedure, right? Numbers really matter, especially when it comes to robotic surgery. Like the learning curve on robotic surgery doesn't seem to be like the learning curve for other procedures where you would get better at it and become proficient in maybe 10 or 20 cases. A robotic surgeon might have to do 200 cases before they're plateauing on their ability level, right? Their proficiency sort of peaks out after like around 200 cases. At least the last data I saw suggested so. And so if someone's going to do a robotic procedure or sacral colpopexy, which is a great procedure, I think, you want to ask them, how many have you done? And if they say 12, that's probably not enough, right? You want them to have done probably more than 200. And so that is something you can arm yourself with. With the cystocele repair, sometimes docs will use biological grafts. It's really fallen out of favor. They don't seem to last or work very well. In my opinion, a native tissue repair is preferable unless you're redoing a surgery. So they've had surgery, it's failed, now you're doing it again, then you might be more likely to use a permanent synthetic mesh, right? Something like that. And the vaginal surgery is quite safe. Actually, there's low complication rates associated with it, but it's always possible to get an infection or have intraoperative bleeding or postoperative bleeding. Sometimes the suture line in the vaginal skin can break down, or the edges of this cut edges of the skin can pull apart and bleed, and that might take you back to your doctor's office. Usually these things can be handled without going back to the operating room, fortunately. And like I said, the surgery is usually successful. Now, in addition to that, we should probably talk about rectocele repair, the second most common vaginal reconstructive procedure that's performed. A rectocele is sort of a herniation of the back wall of the vagina, the posterior vaginal wall, into the vaginal opening and sometimes beyond, creating an uncomfortable bulging sensation. Sometimes stool gets trapped, and in that hernia, in that bulge, makes it hard to poop right, and women kind of figure out they have to splint the perineum or the back wall of the vagina to facilitate having a bowel movement. And it can be uncomfortable and distressing. And so repair of that defect, which is very common, is often indicated. And that procedure is sometimes called a posterior colporrhaphy. And it's kind of done in a similar way to the anterior colporrhaphy. An incision is made along the midline of the back wall of the vagina, and that skin is elevated off the rectum, which lies right underneath that back wall of the vagina. And then I think most docs would sort of suture together, create a colporrhaphy, a line of sutures that gathers up the connective tissue in the midline to recreate a shelf of support over the rectum. I prefer the site-specific repair, which identifies where the actual tear in the membrane that used to exist between, that used to exist between the vagina and rectum was. You can find it and suture it back where it belongs. The outcomes data comparing those two approaches is discouraging because it doesn't show that my approach is better. It shows they're about the same, actually. But I think in terms of recreating a normal anatomy, the site-specific repair always made more sense to me. And I did it a million billion times and got efficient and good at it. And so that was my choice of how to do that particular operation. If you're having a more involved surgery that involves suspending the top of the vagina as well, and or fixing a cystocele, sometimes a surgeon, especially robotic surgeons, like to perform a robotic sacral colpopexy. And this operation is really quite a beautiful operation when done correctly, whereby and usually after hysterectomy, not usually done at the same time as hysterectomy. So now we're talking about people that have had a hysterectomy in the past and now are having a second or maybe their first vaginal reconstructive procedure to address a prolapse. And in the course of this operation, the bladder would be dissected off of the top wall of the vagina, but from above, right? So I know I'm challenging your three-dimensional ability to visualize this, but if you're doing a laparoscopy and looking down into the pelvis, you can create a space between the top wall of the vagina and the bladder, and you can do the same thing between the back wall of the vagina and the rectum. You create these channels, if you will, and you can suture mesh into each of those channels and then over the top of the vagina before securing it to the strong connective tissue in front of the sacrum. I know it sounds nuts, right? But it works really good. It's a great operation when done correctly, and has a low complication rate. And so that is another way of addressing a rectocele or a cystocele for that matter. You can do all at once robotically. It takes a couple of hours usually, so it may take a little bit longer than the vaginal approach. But like I said, if you're doing a more involved, complete reconstruction of the top wall of the vagina, the highest portion of the vagina called the vaginal apex, and the back wall of the vagina, if you're doing all three compartments, sometimes doing that sacral colpopexy is the best choice. And like I said, the success rates are pretty good, probably in the 85% range, something like that. Whether it's posterior colporrhaphy or the sacral colpopexy approach, the success rates are very high. When you have vaginal surgery, like the two operations I've described, anterior and posterior colporrhaphy, generally for several hours after surgery, there'll be a pretty good sized packing inside the vagina that you'll wake up, feel a lot of pressure as a consequence of that. And what that's doing is it's putting pressure on the small blood vessels that might otherwise bleed and create a collection of blood called a hematoma, either under the bladder or on top of the rectum. I mean, that is the last thing you want, because that blood that collects there eventually has to drain, and it's going to be an unpleasant experience if 10 days, 2 weeks after surgery, you start having profuse bleeding. It's not active bleeding because it's just a collection that's draining, but it scares the patient half to death. And so you really want to avoid that. And so leaving that packing in, I'd always leave it till the next morning. But sometimes docs now will take it out just a few hours after surgery. It seems to work okay that way. I just never did it that way. It's funny, like, when I trained, patients used to spend the night in the hospital. I loved that. I liked that they would spend the night in the hospital. I knew where they were. I could see them in the morning. They wrote their vitals on a clipboard on the end of the bed. You could find them. Now, you don't see patients' vitals hardly at all anymore because the nurses don't enter them into the computer system until the end of their shift. So you have no idea what's been going on the last 6-8 hours. Anyway, that's a little bit of a rant, but it really, I think, diminished the quality of care when all of this went digital. Worked really good writing it on a clipboard and putting that on the end of the bed. But then I think HIPAA decided, well, someone might see what your diastolic blood pressure is, and that'd be a violation of your private, ridiculous, stupid, and then damage people's care because of that kind of ridiculousness. But, it's the way it is now. And I don't think it's going to change. So, we talked a little bit about hysterectomy kind of in a cursory fashion, saying you're not going to have that sacrocolpopexy with the uterus in place. There are ways to do it. No one does it that way. It's 99% of the time done after hysterectomy. And so if you're having surgery for uterine prolapse, you can do a colpopexy, but most docs wouldn't do that. I think it's safe to say. If you're going to have a hysterectomy at the time of surgery for vaginal prolapse, right? Often, there's nothing wrong with the uterus. It's just the support around the uterus that's failed, that's allowed that cervix and the uterus, the top of the uterus, to drop into the vagina or to or beyond the vaginal opening. That's uterine prolapse. And in my experience, I was very comfortable with vaginal hysterectomy. It is the safest, most efficient way of performing hysterectomy. So if your doctor's trained that way and is good at that operation, that's great for you. That's a good operation for vaginal prolapse. But what really matters isn't how they get the uterus out. It's what they do after the uterus is out to recreate the support at the top of the vagina. Because if they don't do that, then you're going to be left with an apical vaginal prolapse. And so, there's really two main ways that gynecologic reconstructive surgeons repair apical prolapse. And one is called a uterosacral ligament vaginal vault suspension. Uterosacral ligament vaginal vault suspension. And that's done through the vagina. And suture material is used to take a good purchase of the uterosacral ligaments pretty high up in the pelvis, and then those are sutured to the top of the vagina, to each side of the vaginal opening. So after the uterus is out, right, there's the uterus is gone. There's a hole at the top of the vagina looking into the abdominal cavity, and you're going to suture the bottom edge of that opening and the top edge of that opening to those strong ligaments on either side of the pelvis. And when you tie those knots down, it pulls the top of the vagina up to a pretty high position. And that's a great operation. There's a little bit of a risk that you're going to obstruct a ureter when you're getting those uterosacral ligament bites, right? So you always look with a cystoscope to make sure the ureters are working, before you leave the operating room. It doesn't matter how good you are at this operation. Every now and then you get one, and then you have to go back and take it down and do it again and look again and confirm that the ureters are working well. That is a risk of uterosacral ligament vaginal vault suspension. The second way that doctors handle apical vaginal prolapse or support defects is called a sacrospinous ligament fixation. Now, the sacrospinous ligament is this ligament that exists between the spinous process of your pelvis, which is this little pokey deal that comes off of your sits bone, the Pilates instructors call them sits bones, ischial tuberosities, but you know what I'm talking about, right? There's a little pointy deal on each of those, and between that and that triangle-shaped bone called your sacrum, between the spinous process and the sacrum is a ligament called the sacrospinous ligament, and it's super strong. And you can get a good purchase of that, generally through the same incision you would use to perform your rectoceal repair. You can create a dissection right down to the sacrospinous ligament, get a good portion of that, and then use that to secure the top of the vagina pretty high in the pelvis. It does end up slightly deviating the top of the vagina to one side or the other. Most 9 out of 10 docs, I think maybe more, would use the right side to capture the ligament than the left side, and it may deviate the vagina slightly posteriorly towards the rectum, such that it's felt it can perhaps confer a risk of cystocele or recurrent bladder prolapse because of the angle of the vagina being changed. In my practice, I did a lot of these operations and really never felt like those patients were developing more cystoceles or recurrent cystoceles, but there is literature that reports that, so it's probably true. I think people have gotten away from using permanent suture material for this kind of surgery. Delayed absorbable suture material that may take 6 months to completely get reabsorbed seems to be the preference for most docs. But if your doc's 70 or in their late 60s, they may still use more permanent suture material. Those old guys really like that. And their patients seem to do okay. But I always like sort of the delayed absorbable, and I'm not that old. So again, that's sort of doctor's preference, and you don't want to micromanage that. But it's a good operation. And, if your doctor doesn't do vaginal surgery, it's not the end of the world. If they can do a laparoscopic hysterectomy, great. That's a great operation also. A robotic hysterectomy, great operation also. You want them to do what they're most comfortable with. And they all are less invasive than a big abdominal incision, right? That's, when in the old days, before we had all these advanced laparoscopic techniques or robotic surgery, like a lot of people had a laparotomy, a big incision in the abdomen. And that is more wounding to the patient than the surgery you do after making that incision, right? It's that abdominal, especially a big vertical abdominal incision is quite wounding. And in terms of the patient's experience recovering from that, that's most of what they're recovering from, and it kind of kept them from doing too much too quickly afterwards, which as a surgeon, you always kind of felt, well, that's letting the surgery set up without them running around too much and challenging, the sutures as healing takes place. You want them to not be lifting too much or doing too much. And if they were more wounded because of the surgical approach that they couldn't do too much, you always felt, well, maybe that's helping them heal better. I know it's kind of cynical, but it's true that, these patients sometimes with these newer, minimally invasive techniques feel so good afterwards that, they're out shoveling snow the week of surgery. And you don't want that, right? As a surgeon, you don't want that right after surgery, because the surgery is setting up and it's at its weakest state right after. You don't want to challenge it. You got to give it time to heal. And that doesn't mean you acquire a permanent disability. You can never lift more than 5 pounds again. That's ridiculous. You got to live your life, right? But you got to give it, 6 to 12 weeks to set up, right? It's as strong as it's going to be by 6 months post-op, and then, live your life. But being a little bit conservative on the front end makes good sense, right? And so those are the main operations, that you would think about, that you would probably offer. That's kind of what's on the menu, if you will, for women that are embarking upon a surgical journey. But if you have prolapse, one, you get educated about it, right? Don't go in completely naive to what the options are, what the risks are, what the benefits are. Take the prolapse course. It's a 5 weeks, I think, and Heather can verify that in the chat. And you will know more than 90% of women embarking upon a prolapse problem, and we'll obviously do our best to help you not need surgery. And so this just seems like a great service. That's why we created it. And so check out that link in the chat, in the description of this video, and that'll get you to the right place. Anyone with overactive bladder or stress incontinence that is thinking about being proactive and not just living with it, good. That's really good. Check out the free service that we have through the other link that's in the chat and in the description. You can learn one of the Pilates movements and a lot about our philosophy, and ultimately, hopefully, get signed up for the Pilates 149 course. It's a 2-hour online webinar. Got to listen to me talk a little. And then Heather takes you through all 10 movements, helps you score the movements so that you can pick your best 2. You're going to throw out almost all the movements. You're only going to pick 2. Those are your movements. And those are the movements that you'll do 5 minutes in the morning, 5 minutes in the evening, every day. 80% of our participants that start this process are at least 50% better in terms of bladder control symptoms in 28 days of training. So 4 weeks of Pilates should be sufficient in terms of bladder control problems. Prolapse problems take a little longer, 90 days. It's a different problem mechanically. So you have to be a little bit patient. Same with bowel control problems. Takes longer in terms of pelvic floor fitness training to mitigate those symptoms, but they can and do get better. So be patient. Give it 90 days. Either for prolapse or if you're having a fecal incontinence problem. Pilates works well for that. Overactive bladder, stress incontinence, mild to moderate prolapse are the indications for doing the simple but hopefully consistent training called Pilates. The Pilates method has been around for 15 years, 16 years now. And we have trained thousands and thousands of instructors and helped hundreds of thousands of women, I guess. And we're really pleased with those results and would like to share them with you. So check out that free movement at least. It doesn't cost you anything. Links below. Someone's asking, what about a vaginal burning and prolapse at the same time? Great question. Those can be separate problems, unrelated to each other, or they can indeed be related. For instance, if your prolapse is such that the vaginal bulge is outside the vaginal opening most all the time, like a lot of women, as prolapse is evolving, they'll notice a bulge sometimes, like, if you're standing for a prolonged period of time or sneezing or bearing down. But a lot of the times they don't have a bulge, and the bulge has receded back above the vaginal opening. But if it's not doing that anymore, if it's staying down, if you will, then the vaginal skin can start to rub against clothing, what have you, and erode and actually develop an ulceration that could cause discomfort and bleeding. In addition to that, there's a lot of reasons why women experience vaginal discomfort. Some of them are infectious, like candidal overgrowth, sometimes called a yeast infection, easy to treat. Sometimes it's related to nerve problems. There's a disease state called vulvodynia that has probably more to do with nerve dysfunction than it has to do with anything you could identify anatomically. It's not infectious, but sometimes the nerves in a particular area of the vagina, like right at the opening of the vagina at like 5 o'clock and 7 o'clock, there's these glands that for some reason get very sensitive, and it's not clear that it's always an infectious process, although it certainly can be. And that can be treated generally with topical medication, but sometimes systemic medication is necessary when treating that kind of a problem. But a vulvodynia is totally separate and unrelated to a vaginal prolapse, right? It's just the vaginal skin isn't designed to be exposed to the outside world, so it doesn't have this layer of a how can I put this? Like the skin on the outside of our body is designed to be exposed to the outside world, right? And so there's layers of dead cells, if you will, then or cells with that have excreted protein that keeps them from becoming dehydrated. Vaginal skin doesn't have that, right? Unless it's exposed to the outside world for too long, and then it starts to develop a keratin layer on it that makes it kind of rougher and thicker and uncomfortable. And so if that's the case, it is probably time to either think about a pessary device or possibly a surgery, and talk to a doc about that. But it's just as likely that those two symptoms are unrelated. So I hope that has been informative. I've been talking for an hour, and I'm going to wrap it up pretty soon, unless there are some more burning questions. If there are, please do share. Man, look at the chat. All kinds of information that Heather has been handling, and that's so awesome. I feel slightly excluded, however. So if anybody has a question for me, I'd be happy to entertain it before we wrap this up. This will be posted in the next day or so. So it'll be, it's dark in here now. It got dark while we were talking. Hold on a second. That's a little better. It'll be online. Come back to it. Check it out again. And if you are talking to a doc about what your management options are, then this should help you go in more confident and informed, and able to ask questions directly. Remember, this person works for you, right? Sometimes I think patients feel like they're in a subordinate position, and that, out of either respect or I don't know, well, they're intimidated and afraid to ask questions. You've hired this person to work for you. Make use of them. They're a consultant. Be respectful, but get the information you deserve. There's nothing wrong with that. Let me tell you something else. There is no good doctor that is offended by their patient getting a second opinion. I often recommended that to my patients. You can tell when patients just not settling into a particular therapeutic plan, they're uncomfortable. I would encourage a second opinion. Every doctor that's good would encourage their patients to get another opinion. That does not offend a good doctor. So don't be afraid to do that either, especially with something as important as what we've been talking about, right? Right. All right. You guys are awesome. Our YouTube channel, The Pelvic Floor Solution, deserves your subscription. So please help us out by subscribing. And if you like this, if you thought you got something useful out of it, I hope you did, like the video, share it with somebody. And, maybe you'll think of a question that you didn't have while we were live. Write it in the comments. I see every single question, and I'm happy to do my best to answer those questions. All right. Thank you, folks, for hanging out. Thank you for your attention. We'll be posting a new video soon. I'm working on this autonomic series, and the next one's about autonomic dysfunction and the cardiovascular effects of that. It's really turning into this cool, it's more work than I thought it would be, but it's going to be a cool project. Probably break it up into a few pieces, so that you have that to look forward to. If you're a subscription and you have the notification bell activated, then you'll be notified as soon as we drop a new video and you can stay informed. Okay, bye.